I'm delighted to open the annual Irene and Hyman Kreitman Memorial event. My name is Professor Halleli Pinson. I'm the Presidential Advisor for Gender Equity, and I'll be moderating this session. So a few words about the event today. Ben-Gurion University of the Negev remains extremely grateful for the tremendous generosity and support of the late Irene and Hyman Kreitman, who were among the most loyal and devoted friends of the university from its inception. Irene and Hyman passionately believed in the importance of creating an institution of higher education in the Negev. They recruited many of their friends around the world to join them in empowering what was then a fledgling institution, and Hyman served as a chairman of BGU Board of Governors. Over 3 decades, Irene and Hyman were dedicated to the success of the university, playing an instrumental role in both of its physical and academic development. It is our honor to remember the Irene and Hyman Kreitman here today with this annual event held in their memory. And this year, Kreitman Memorial event was inspired by the work of 2 of our honorary doctorate recipients, Dr. Chelsea Clinton and Dr. Segenet Kelemu. And the event is, as you probably know, is dedicated to the theme of global health and gender equity challenges. The United Nations' 3rd Sustainable Development Goal makes global health a priority. It emphasizes the necessity of developing a gender-sensitive approach in order to address health-related inequalities globally and locally. The panel really brings together 5 incredible women together in conversation, and each one of them is an advocate through means of research or social activism or both for a gender-sensitive approach to global health. The panel will address some pivotal questions such as what are the consequences of gender biases on women's health and access to health services, the importance of having more women in global health leadership, and what approaches and perspective do we need to develop in order to address the health needs of women from minority groups and low-income countries. The panel also will touch upon some contemporary topical aspects of gender and health services, such as dealing with global pandemic. COVID might be quite a near memory, food security issues, and also the consequences for women's health of current political changes. So let me first introduce our panelists. So first, Dr. Chelsea Clinton. Chelsea Clinton is the #1 New York Times bestseller author, advocate, and public health expert. As vice chair of the Clinton Foundation, Dr. Clinton provides vision and expertise to flagship programs like the Clinton Global Initiative, a model for public-private partnership to address today's most pressing challenges, Too Small to Fail, which is a project that supports families with critical resources to promote early brain and language development, and the Clinton Global Initiative University, a global program that empowers students, leaders to turn their ideas into action. Dr. Clinton also serves as the vice chair of the Clinton Health Access Initiative, which has helped over 11 million people in more than 70 countries access critical HIV medication and works across more than 125 countries around the world to build and strengthen sustainable health system. In addition to her foundation work, Chelsea teaches at Columbia University Merriman School of Public Health. She holds a Bachelor of Arts from Stanford, a Master of Public Health from Columbia Merriman Schools of Public Health, and both a Master of Philosophy and Doctorate in International Relations from Oxford University. She lives with her husband and 3 kids in New York City. Dr. Segenet Kelemu is an Ethiopian scientist known for her work as a molecular plant pathologist and outstanding scientific leadership. For close to 3 decades, she has led a research team dedicated to addressing agricultural constraints in Africa, Asia, Latin America, and North America. Since 2013, she has been the Director General of the International Center for Insect Physiology and Ecology. Previously, she served as a Director for Biosciences Eastern and Central Africa. Vice President of the program of the Alliance for a Green Revolution in Africa, and leader of a crop and agro-ecosystem health management at the International Center for Tropical Agriculture. Dr. Kelemu has received many international accolades, including the L'Oréal UNESCO Award for Women in Science in 2014. In addition, she received recognition as one of Forbes' African top 100 most influential African women in May 2014, was mentioned as one of the 10 most influential African women in agriculture by the Journal of Gender in Agriculture and Food Security, and was elected as a fellow of the African Academy of Science. And we have great pleasure of having you here with us. We also have here at the panel 3 of our own BGU researchers from the School of Public Health, the largest school of its kind in Israel. During and following the COVID-19 pandemic, it has positioned itself as a leading interdisciplinary research and teaching institution, invested in top-notch research initiatives ranging from basic science, clinical research, epidemiology, health policy, and global health. The school, as you will learn from our panelists as well, is dedicated to community engagement in the Negev, and students and researchers focus on health promotion and reducing health disparities. So from the School of Public Health, we have Professor Dorit Nitzan. And Professor Nitzan joined the School of Public Health in 2022, just a mere year ago, as a full professor, and serves as the director of the master's program in emergencies, medicine, preparedness, and response. In addition, she is the director of the Mania Igal BGU4 Research Center, which emphasizes food system, One Health, and resilience. Dorit came to BGU from the World Health Organization, where she served since 2005 as the WHO representative and head office in Serbia and then in Ukraine. And since 2016, she was based at the WHO regional office, most recently as the regional emergency director. She returned to Israel in August 2022 after being recalled by WHO to lead the incident management team and the WHO humanitarian response in Ukraine. She also participated in many national and international committees in the fields of emergency, health and food security, epidemics, gender sensitivity, and innovation, emergency preparedness and response, and I cut some of the different committees she's part of. She has received prestigious awards from the WHO, the United Nations, Israel Ministry of Foreign Affairs, and hospitals where she has served. Dr. Anat Rosenthal Dr. Anat Rosenthal is a medical anthropologist of the Department of Health Policy and Management at the School of Public Health and at the Tamar Golan African Studies Center. Her research focuses on global health policy and healthcare delivery in resource-limited environments. She has conducted fieldwork in Israel, Malawi, and Zimbabwe on the social and cultural effects of age, healthcare delivery, and in resource-limited setting. The impact of climate change and health services, national and international health policies, and undocumented migration. Dr. Rosenthal's work has been published in prestigious journals in medical anthropology, public health, and medicine, and her book, Health on Delivery, the rollout of antiretroviral therapy in Malawi, was published by Routledge in 2017. And last but not least, Dr. Hanin Shibli, who just earned her PhD quite recently, which is, I think, a word of applause is required as well. So Dr. Shibli was born and raised in a small Bedouin village in northern Israel called Shibli. As a minority Bedouin Arab woman, she managed to cut across traditional, cultural, and academic boundaries and become the first woman in her community to pursue a PhD in public health. Her research focuses on the accessibility of health services among the Bedouin Arab community in Israel, particularly among Israel's most disadvantaged group, Bedouin Arab women. Her research centers on social matters and gender issues and uses the sociological lens of intersectionality and social determinants of health. She has been working on COVID-19 responses among the Arab minority and Bedouin Arab minority in Israel, as well as the awareness to HPV and HPV vaccination among young adults in Israel. So, thank you. So I'm moving here and joining this amazing women conversation. What? Oh, no, it's working. So, Chelsea, I would like to start with you and ask you, as an expert in public health and advocate for gender equality, if you can get us started and explain why, beyond the normative imperative, we need to look at gender issues, why gender matters when we talk about global health systems.
Oh, goodness. I get to start with the easy question. Well, Halleli, I want to thank you and everyone here at BGU for welcoming us so warmly, particularly for all of your patience and forbearance. I broke my foot last week, and so it will be fine, but thank you. And so I move very slowly. But please don't think my slow pace is any equivalence to my enthusiasm for being here. It's just the kind of honest reflection of paying attention to my doctor's advice, and even many thousands away from New York City. So Halleli, you ask about kind of why we have to pay attention to gender, and I want to answer it both kind of in the health context and also then kind of beyond the health context. I mean, in the health context, you said, beyond the normative dimensions, also taking hopefully for granted just the practical dynamics that if we're going to leave out over kind of 50% of the world's population, we're not going to ever kind of move forward on any kind of meaningful kind of health target or anything meaningfully like equity in pursuit of those health targets. And I think particularly now, this conversation has real urgency because of all of the ground that we've lost in the last few years. The ground, of course, that we lost as relates to COVID, but also the ground that we've lost in my country and in other countries as women's fundamental rights are being rolled back. And it would just feel disingenuous for me as an American to not acknowledge that, because I think oftentimes these questions are framed as kind of what is happening in low and middle income countries, and yet we have deep gender inequities in my country, particularly when it comes to health, and they are only growing more exaggerated and worsened because public health has once again been politicized, and people's fundamental human rights have once again been kind of determined in the political arena and kind of instead of their own kind of personal realms. And so I think that's the kind of broader context. I think, though, specifically, one thing that I'm sure Dorit, particularly sitting next to me, has spent even more time thinking about it than I've thought about is oftentimes when we think about kind of gender issues in health, we think about only patients, and we don't think enough about providers or healthcare workers. And yet most of the people who deliver healthcare around the world are women. The majority of community healthcare workers are women in most countries. The majority of nurses are women in most countries. Increasingly, the majority of doctors in most countries are women. Growing numbers of researchers, like Professor Kelemu, are women. And so I do think it's also about ensuring that we are providing the best possible care with the most dignity, and also ensuring that we are orienting our research to help benefit the most people possible, that we have to also be mindful of gender, because we know when we're not mindful of gender, as we were talking about earlier, Halleli, we don't then live in a gender-blind world. We actually then manifest a world in which women and girls have fewer rights and fewer opportunities. And so we need to be mindful of gender, not only as we think about patient health and population level health, but also as we think about who's enabling that health and then who's doing the research to help facilitate better health in the future.
I want to follow up on that and ask you maybe more, kind of a more specific question. And I mean, how girls and women from, the work you're involved in are impacted by global health system, and what sort of old biases and discriminatory practices and new biases and discriminatory practices impact access to health, for instance?
Well, I think about the late, great Dr. Paul Farmer, who I was lucky enough to know and to learn from and to be mentored by and to work with over many years. And for those of you who may not know Dr. Farmer's work, he was one of the founders of Partners in Health, and really not only kind of a advocate for, but a kind of demonstrator of kind of what he always called the preferential option for the poor. And that if we actually built real systems, meaning, had robust organization, had actual dignified spaces, clinics, hospitals, had well-trained people, so the staff working in those clinics and hospitals had enough stuff, so enough kind of medicines, tests, screening, modalities, treatments that poor people anywhere could receive as good health care and then achieve kind of as good health as anyone anywhere. And he proved that from Malawi to Haiti to Peru to Chiapas in Mexico to Siberian prisons, to the Navajo Nation reservation in the United States and well beyond. And so he had what he called like the kind of taxonomy of the 4 S's, right? You needed to have a well-organized system, you needed to have enough stuff, you needed to have enough space, and you had to have enough staff. And if you had those 4 S's, anyone, anywhere should be able to access good healthcare. But of course, that also then required, kind of legal and cultural and normative infrastructure around that. And so, one of the areas that I do a lot of work on in the United States, but then in partnership also with others around the world, is trying to end the practice of child marriage. Because nothing is a greater indicator for a woman's lifelong poor health than if she is married as a child and if she gives birth to children as a child. And in the US, child marriage is still legal in 42 states. And I think that's abominable in the 21st century. And I think we can't be talking about the Sustainable Development Goals and talking about what we need to do to help protect women and girls and to eradicate child marriage around the world if we don't take ownership for what's happening in our own country. And so while I appreciate and work very hard kind of in my day job on the 4 S's, kind of on my personal advocacy side, Halleli, also trying to be mindful of how climate change and other kind of environmental factors, quite literally, but also metaphorically, very much are constraints around whether or not girls and women are able to fully lead their lives kind of with every kind of aspect and dynamic of health that they and any of us deserve.
Well, thank you. And it's not working. Oh no, it's just he controls my. Okay, fine. Okay, so Dorit, I want to move to you and ask you. I mean, you have a vast experience working with WHO, and in our preliminary conversation, you said something that really resonated for me based on your work there, and this is that gender must be a pillar in any global health program. And I want to ask you if you can elaborate more. What do you mean by gender being a pillar, and how do we do that?
Yeah, thank you, and I'm really privileged to be here. Thank you so much. Well, women and gender and sexual minorities, in emergencies, we see the extreme. We see where they are in reality. The emergencies reflect the diseases of society, and it really pull and push those, the women and the gender minority groups into the margins and away from everything, the hands, the shoulders that we see there. What we also see that those groups are actually becoming the core, at the heart of the atrocities. When there are conflicts, they are the first to hit, the first to get everywhere, all the impact of the bad things. And I'm really happy because we worked with your organization in many, many countries. And we learned through the years that we need to combine. We need to combine what we call the horizontal and the vertical approach. In the horizontal approach, what we do is we put gender and sexual minorities issues into each of the topics that we go, let it be protection, treatment, logistics, everything. You know, we go cross and we put it in a matrix. We never can do something without including it. But we learned that it's not enough. We need to have a vertical approach, a pillar, I called it, I think, in that discussion. That pillar is a gender and the sexual minority specific pillar where we put a vibrant network of partners together. They assess the data, specific data. They do the analysis, they prepare the basis for the prioritization and the actions. We learned that without that specific pillar, we are going to miss not only the care for these groups, but also the opportunities for the future, because we really need to make sure that what is done, to use the emergency as an opportunity to build better.
Can you give an example of such a kind of an approach being implemented?
Well, there are the approaches that I can see is, for example, in Ukraine. That's where, you know, the latest one. Or before in Ethiopia, in the cholera outbreaks. What we did, we analyzed the situation. Every one of the pillars that we did had gender approach for HIV/AIDS, for diseases, for mental health, social inclusion, etc. But we also had a pillar that took the community, really invited the community into the cluster to discuss. We learned from them what they need, and they dictated, they gave us the hand to move forward. So, you know, these are unique opportunities that if you take that, and we hope that they will be stronger in the future. We escort the communities in Ethiopia, in Ukraine, in Serbia, in Turkmenistan, you know, in each of the countries through their process. I'm talking about health, but we do it in more comprehensive manner with other organizations.
May I just say quickly, too, that I also think it's crucially important that Dorit is there and that we have now so many women, particularly in leadership positions at WHO, because I do think, you know, who's sitting at the table matters. And for most of time, conversations like this have been male-dominated, and still today, you know, most panels, you know, I think could still be male-dominated, but for particularly women in global health, saying we're not going to speak on a panel if we are the token woman. And so I do think it's sometimes these small things that hopefully help kind of lead to and then kind of undergird and sustain larger change. But I think Dorit is being a little too humble for what not only she, but WHO has really been a leader in the kind of development architecture to ensure that kind of women were at the fore of being mindful of how best to account for gender and embed gender in emergencies and non-emergencies alike.
Well, thank you, Chelsea, and also hence the composition of this panel. Okay, so I want to move to Segenet and also bring us to an additional, to add an additional issue to the conversation. And you really bring in expertise in a very important aspect of global health, which we not always considered as part of global health, but it is, of course, this food security and nutrition. So in the context of the global South, especially, what are the main challenges for women's health, and how are they linked to food security?
Okay, thank you everybody for this honor. Definitely food security is really important. It is everybody's issue. It's not just a global South issue. And gender equality is also everybody's issue. Everyone, at least a commonality, everybody has a mother at least, right? So, Unfortunately, we are far, far from equity, far from food security. The basic needs of humanity, the #1 need for well-being, health, is food and nutritional security. A person who doesn't have food, really everything else becomes irrelevant. But unfortunately, in this planet of plenty, around, according to a 2021 figure, around 2.3 billion people are either severely, moderately, or severely food insecure. And most of these are in the global south, and most of them are women. So poverty, there's nothing more degrading, more dehumanizing than not having enough food, and you have to beg for it. I tell you, because I come from that end. I grew up in a poor village in Ethiopia. And when Dr. Clinton talked about child marriage, I was smiling inside because I skipped that child marriage. The village where I come from, girls are married off by the age of 10. Often parents are making arrangements while the child is in the womb. If it is a girl, I want your daughter for my son. But I skipped it because I was too rebellious and too tomboyish, and I was not marriageable. So nobody wanted me. So that was great. Otherwise, I wouldn't be here today. And I think, so there is a strong linkage of food security, gender equality, and global health, and everything else together. And for example, 99% of the also maternal health of the estimated 287,000 maternal health around the globe happens in the global south, in the women. And so because of lack of nutrition, lack of also the basic essential healthcare services. So this should not be acceptable to anybody, to any of us. We should be outraged by that. But on top of that, also the neglected tropical diseases. The vast majority, of course, both men and women are affected, but the vast majority of neglected tropical diseases happen in the global south. And Africa alone bears the burden of 40% of these diseases, and this is not acceptable. But the good news is that studies show that programs that address gender barrier actually improve development outcomes. When women are educated, have incomes, have also control over their incomes, child mortality declines, the food and nutrition security of the household improves, and also poverty cycle can be broken, and there are a lot of things that happen, and so society as a whole improves. But for this to happen, a strong political will is needed, a very strong political. So the SDGs talk about global health, food security, gender equity, a lot of different things. So nobody can argue about that. The problem I have with the SDGs is none of it is binding. So countries, if they don't want to do it, there is no penalty associated with it. The other problem I have, the second problem with that, is that the measure for poverty line is too low. The poverty line is $1.90 per day. So $1.90 per day, whether you are in New York or in Tel Aviv or Nairobi or Timbuktu, it doesn't buy you even a decent cup of coffee. So this is not realistic if you want to challenge, to break that poverty, to bring equality in gender disparity, to remove that. We have to be serious also how we measure that. I'm sure many of you have pets, dogs or cats. When I had pets, I needed more than, the cat cost more than $1.90. to live per day. So are we going like a few years from now, come and say, okay, now 200 million people around the world are making $1.95 a day, and so that we have broken poverty? No. So we have to do serious things to solve this persistent and long-lasting issue. I don't want to talk about gender inequality every March 8th. I want to do something about it, and everybody should do something about it. Thank you.
Thank you. Thank you. That was so important. And I think, Anat, you can follow from here. And
that's a tough act to follow.
Tough act to follow. But I mean, when again in our preliminary conversation, we spoke not only about the challenges, but also about the solution and both the global and the local perspective of such solutions. So if you can pick on that.
That's a really tough act to follow. So thank you. It was inspiring. And I think the solution to the challenges come both from global level institutions and from local institutions. So going back to both of your, actually all three examples, thinking on the global level and the global system, it definitely plays a very important role in setting agendas, even if they're not good enough, but at least they're there. We've gotten used to them, and we forgot that a few years ago we didn't even have agreement on that. And the focus on women's health, both in high and low income countries, but obviously in low income countries, these global institutions play a much bigger role. And just going back to thinking about health systems and women in health systems. So for example, just thinking about the issues of women's status in society, access to education for girls and women, and the crippling shortage in healthcare workers, right? All these three crises intersect in a way. And in many parts of the world, this shortage is so big, and I think a lot of us operate in these systems where you can't get a healthcare worker when you need one, and countries are struggling. And some of these solutions could come from global institutions, thinking about the Sustainable Development Goals, for example. So goals 4 and 5, quality, education, and gender equality. The mechanisms put into these systems, if we use them correctly, and if we have high expectations, could actually solve a lot of these other issues. And in preparation, I looked at the World Bank data for education for girls. So just 2 examples. In India, in 2022, only 75% of girls were registered in secondary education. In Afghanistan, in 2018, which is the last year we have information for, it was 40%. Girls who never went to secondary school will never become community health workers, physicians, nurses. They're not going to be part of the healthcare system. And we have this major global crisis in health workforce, and we're missing out on more than 50% of the population. And I think in that sense, the role of women in global health is not just to be patients, but also to be healthcare providers, and these global mechanisms could be a part of the effort to move forward if we use them correctly. But these are the global institutions, and a lot of the challenges and the solutions are very local. And I want to give 2 examples that are close to my heart and some of my colleagues at the School of Public Health. And they both are connected to women's health, and they're both in sub-Saharan Africa, which is where I do most of my work. And one of them is based on a project that we have at the School of Public Health in collaboration with the University of Zimbabwe and a local rural hospital, which I will not name. And that hospital struggles with very high rates of cervical cancer in women who are HIV positive. And this goes undiagnosed, untreated until very late. And the women who suffer from cervical cancer are marginalized, stigmatized, and die because they don't get the care that they need. And what the hospital was trying to do is figure out a way to reach out to these women. The Sustainable Development Goals are not going to help them. But what would help them is a hospital that integrated HIV care, which does exist in the community, under 5 care in the community, with screening for cervical cancer. So when women come to vaccinate their children or to get their HIV medications, they get offered screening tests for cervical cancer. So that is one kind of solution, finding the right integration for the right place and do it at the local level. The second example I want to give and I think Dr. Clinton is going to enjoy it, comes from our collaboration with Partners in Health in Malawi. And the project that was led, by the way, by a graduate student of ours at the school, went back to the communities that were affected by climate change, by a local cyclone. And not surprisingly, very sadly, but not surprisingly, we realized that the household that had the hardest time recovering from the storm were a household led by women, widowed women, marginal women, women with disabilities, women who were taking care of children with disabilities. They're the ones who could not build their homes 6 months after the storm. They were still living outdoors with their family. And what that study taught us was that in communities that had strong institutions during routine times, not when the storm came, but between storms, were the communities that were able to support these women in getting back on their feet. And in that sense, the solutions come from building and maintaining permanent institutions for welfare, for healthcare delivery, having access to clean water year-round, not just when the truck comes. That actually changed the status of these women in their communities. They were no longer marginalized the way they used to be, but it also helped the whole community cope with the crisis. And I think these are two interesting examples of how the solutions can come from the community and build from the community. Ideally, I would love to see strong staff systems, spaces, and I would like to see higher expectations from the global community. But I think the solution is somewhere in the intersection of what the global system can do and what local institutions, communities, and people can also do. And the key is in the collaboration.
Khanin, I mean, you do research on this sort of context of underprivileged women and the intersection between cultural norms and gender. If you can tell us a little bit from your experience in your research, how this intersection affects women's health, and what can we do to, especially in the national and the local, to remove barriers for access to health?
Well, it's a great honor to be here, first of all. And when Dr. Rosenthal said intersection, I immediately smiled. So yeah. So when it comes to access to healthcare services, gender play a significant role in among women around the world, like worldwide. But the challenge becomes greater when we are talking about minority women in some of the conservative community around the world. And I'm talking because it's also personal. I'm talking about the Arab Bedouin community here in the Negev, here in Israel. So I would say that it's not just the gender factor that plays the significant role, it's the intersection with other factors such as social norms, cultural expectations, and some stigma related to some health issues. I belong to the Arab Bedouin community, as Halleli mentioned before, and I also, maybe I'm not facing the physical access barriers because I have a driving license and I can go to the clinics whenever I want, but I also face sometimes stigma barriers and like gender barriers when I want to receive a treatment. Even I'm a doctor in School of Public Health. And I know a lot of women in my community that also face huge gender and the intersection of all these barriers. For example, some women of the community cannot go to the clinics and they need a male chaperone to receive the treatment in the clinics. Other women need a permission from a male family member to even receive a treatment. Some others do not have control over their health decisions, or they cannot make their health decisions in their own body by themselves. They need the male to decide for them. And there also, I mentioned the stigma. So some of the health issues like reproductive and sexual and mental health issues in my community, there's a lot of stigma around these issues. And I want to give an example about, it's a sad example, I have to say, about Bedouin women that I met during my research that I was conducting here in the Negev among the Bedouin community. And the woman at the time she was beautiful. She was an amazing woman, and I think she was strong. She told me that she was diagnosed with breast cancer, and she refused to receive the treatment immediately because she was afraid of the stigma in her community around this whole health condition. She even refused to tell her mother or sister or to share this with her daughters. And we know that breast cancer is actually something that could be potentially caused by the genetic disorders and could potentially affect her, the women in her family. And yet she was afraid of the stigma in the community and the responsibilities that the culture expects from her as a woman, as a wife, in taking care of the children and the household. When she decided to receive the treatment, it was the cancer was progressed to the advanced stages, and it was much more difficult for her to receive the treatment, actually. So yeah, it's a sad example with a happy end, but I think it illustrates the intersection of all the culture and social expectation, and also the gender barrier and the stigma.
Thank you. So I want to move us to a slightly, different issues to discuss and talk a bit more about contemporary impact of gender and global health and kind of current issues. And Chelsea, you mentioned when you started that in the US as well as in other countries we see maybe a regression. And I want to ask you, as a US citizen, how do you perceive the current political changes and how it affects?
The U.S. is 61st in the world for maternal mortality. My original home state of Arkansas has the ignominious distinction of being the worst state in the country in which to give birth. Arkansas really is a place where many of our American challenges coalesce in deeply dangerous ways for women, and so women are often not able to access care for kind of cost or geographic or also cultural reasons. More than a third of women in Arkansas live more than 2 hours away from a women's healthcare clinic. Many are from also quite conservative religious backgrounds in which they are discouraged from accessing reproductive healthcare, birth control in any form. Also, we have a quite high death by suicide rate for expectant and new moms in Arkansas. That has only accelerated as reproductive freedoms have decreased. We also have a high intimate partner violence rate in Arkansas. So pregnant women who are being murdered by their partners, sometimes purposefully and sometimes in a fit of rage in which the death is just an accidental byproduct of the violence. We also have rising rates of death by opioid overdose in Arkansas, where many women are not actually probably receiving the appropriate medically indicated kind of pain treatment while giving birth. Also because of the stigma somehow that it's more maternal to endure kind of the full measure of pain, that somehow that's kind of what God expects us to do. And so we very much see how then the politicization of women's health care has just made all of the pre-existing challenges all the worse, particularly for poor and marginalized women. And it's also not only happening in the South. I live in New York City, where ostensibly we've had Medicaid expansion, meaning the government program for low-income women. We have on paper, enough healthcare kind of facilities and workers and stuff and systems in New York City for anyone who lives in New York City to access. And yet, if you're a Black woman giving birth in New York City, you're 9.4 times more likely to die in childbirth than a white woman, because the long history of racism in our country is not going to be kind of obviated or overcome simply because we now have clinics in more minority neighborhoods. So we have only lost ground because of the recent politics and politicization of women's health, and yet we were not on very stable ground before the Supreme Court decided that we no longer had a right to privacy in the United States. And I think, too importantly, Halleli, this also though does relate again to the healthcare worker shortage in the U.S., which we experience. It is immense in the U.S. as it is everywhere, and that we now have doctors and nurses and midwives and doulas leaving the places that have drastically reduced or removed kind of reproductive health choice and agency, because they feel like they can't live up to their Hippocratic oath, that they can't deliver the care that they need. That, of course, then only worsens kind of the reality for the women patients who are still there. And yet, we do have many courageous and heroic and brave people and organizations working to still provide care in as many places as possible, and also working to address the many different and interrelated forces that make it so dangerous to be a woman giving birth in America, particularly if you're a Black woman giving birth in America or an Indigenous or Native woman giving birth in America. So we have a lot of work to do, but thankfully we have a lot of people who are committed to doing the work.
Anat, if you can briefly refer to also some of the challenges that you see in that perspective, and also, I mean, we talk about maybe regression, but where, in comparison, from your research experience to the Global South, we regress or progress?
Okay, that's a tough one. So I think for the last maybe decade or two, we're all busy with empowering women in the Global South. We all went to workshops and did courses and had syllabi, and everyone was focused on women's rights in the Global South. And I think we kind of lost sight on what's happening in other parts of the world at the same time. And when I sort of look at my friends in other countries, women in Rwanda are 61% of parliament. In Senegal, there is a law of parity where each party going for election, either municipal or national level, has to have gender parity in the party, or else they cannot run. So I think part of it is kind of looking to my friends from other countries and thinking, okay, they've been doing something right and we've been losing ground, as you've said. And that worries me. So in my dreams, the women of Rwanda and Senegal come to the Israeli parliament and say, hey, people, this is how we do it. But in that sense, I'm not gonna lose hope. And I think there is still a lot more work to be done to talk about women's status in society, because it relates, right? Representation in government, in policy making, in health systems, in academia, but not just being there, but actually acting. Because we do know that the fact that there's a woman at the table doesn't necessarily mean that there's gonna be a gender agenda on the table. So how do we move forward and move these agendas to places where decisions are being made? And that's not gonna happen in a place where 40% of the girls go to secondary school. So all these things are connected: education, access to healthcare services, representation, having a voice in politics, in the household, in the community. All these things are connected, and it is heartbreaking to see these processing happening in the US, in Israel, in Poland, in Hungary, and then talking to a Senegalese colleague and hearing about women in parliament. But this is also a reminder that things change. These are processes. So this is not the end of the line for those of us who are a little depressed. They're amazing people, amazing women, but not just, doing the work all over the world. So I am hopeful. I think we have to be.
I'm glad. I want to touch briefly on another challenge we faced recently, and this is COVID-19. And Hanin, especially, I want to ask you, what impact did you see in terms of the pandemic?
Well, we know that the COVID-19 pandemic has unequally impacted some segments or some subgroups in the within the population in the world. And it's actually impacted, the most affected were the vulnerable populations, and especially women and minority women around the world. We know there were also pre-existed disparities before the COVID, and the COVID just came and highlighted these disparities. We saw that a lot of women lost their jobs and they had to stay at home and take care of their children because the school were closed and all these daycare centers that they were closed during the pandemic. And I want to give maybe a specific example about something that sometimes we forget about when we are in the middle of a crisis or middle in the a pandemic, like during COVID. So like the healthcare access, which is a basic thing for us as a woman and as a population, as a minority group. We know that Israel was leading the vaccination rates in all over the world. Everyone was talking about the huge success of Israel in the vaccination. But there were two groups that mainly were affected: the Arab Bedouin women here in the Negev, and also the Jewish Orthodox women who couldn't leave their houses when the vaccination campaign started, because there were no vaccination centers inside the villages or beside like the Jewish Orthodox towns. At first, but only in Tel Aviv, Jerusalem, and the big cities of Israel. So they were kind of left behind, and it took like a few weeks for some of the HMOs and the Ministry of Health to realize and identify this problem. Health policymakers shouted and screamed and said, you should open vaccination centers inside the villages so people could, and women actually could access these centers and receive the vaccine, and they actually fixed the problem. So in my opinion, on daily basis and also on pandemics and crises, of course, we need to address the unique needs of women and vulnerable population and not forget about them. Thank you.
Thank you. I think this is another example of local solutions or local-oriented solutions. I want to end the panel in kind of a more optimistic note and ask both Dorit and Segenet about your experience of the impact that women leadership can have, and especially both being leaders in your field. So Dorit, if you can get us started.
Thank you. Well, I can take it back to the COVID, I think, and I was in Europe, and at that time we had 14 women leaders in Europe. And I can tell you that we saw the difference. Now, I know some of you would say the chicken or the egg, and you know what started it, but definitely what we saw is that countries led by women had more trust, so-called. We saw the public health and social measures being, you know, people complied with them more in those countries. So that actually gave us hope, and we looked at it from different, and we do some research now to assess it. We saw that these countries have much more connection on the ground with the communities. They were more mature democracies in general, and that's probably the chicken-egg thingy. And we saw that the changes and the tailoring of the programs was done, you know, on a daily basis. It was done very well, and that actually, you know, we're thinking about examples of women leaders, right? We're talking about, so who could be? And then I thought that maybe we should take it around the globe. And I would start with an African lady, amazing one. We all heard about her, Ellen Joy Seidlitz, you know, from Liberia, who got the Nobel Prize, the Peace Nobel Prize. She was the one that actually got the conciliation in Liberia during the war there, the conflict, but also the 2014-15, those of us who worked in the Ebola amazing work, what she did. But when she got the Nobel Peace Prize for her work for women, promoting women. So that's the African representative. Then the one from Asia would be for me, Margaret Chen. And then I add to her the Norwegian lady, Gro Harlem Brundtland. And then, if I may, your mother, Hillary Clinton. Because these three ladies, for me, symbolize the universal health coverage, the work, lifelong work for every person on earth, women and others, to have access to services. So I think we can be optimistic. We have those ladies, and we have to have mature democracies to allow them to be the star. So we have to work also here and now. Thank you.
In reaction to what Dora said, since you mentioned my mother. I grew up listening to my mother say that while of course women were more than our reproductive organs, if we didn't have freedom over our reproductive organs, we didn't have agency. And I think that is an important point, that we need to have women included in the conversations around HIV and AIDS. Or currently right now, because I'm here, I'm not in Geneva, where the Clinton Health Access Initiative, along with the Global Fund and the WHO, has convened the first really big meeting ever on hepatitis. Hepatitis is not in the Sustainable Development Goals. If kind of current disease trajectories persist for HIV, AIDS, tuberculosis, malaria, and hepatitis, by 2040, more people will die of hepatitis than HIV, AIDS, tuberculosis, and malaria combined. Even though we have vaccines for hepatitis B, we have very good diagnostics and treatments for hep C, we're making progress on hep A, we're not doing enough to ensure that we have democratized access to those screenings, to those tests, to those vaccines, and to those treatments. And of course, women have to be part of that conversation. We have to simultaneously ensure that we are working on reproductive freedom and agency, and I'm very proud that Chai has been the leader of negotiating, lowering the costs for many forms of contraceptives, including injectable, reversible, long-lasting contraceptives, because oftentimes women are able to access those when they take their children to the well-child visits, where they're able to make choices free from encumbrance of their husbands or partners, and also ensure that women are included in all these other conversations. We have to be able to do both, and I am so thankful that I grew up with my mom expecting me to understand that and then to work in that way.
So, Segenet, if you can bring us to close, and also from your experience, and especially your own, yourself, I mean, if you can talk about being a leader in your field and the importance of your journey.
Maybe? Okay. Thank you. So I think leadership really matters. It can be good leadership by women. It could be great leadership by men with their femininity surfacing. So I think the COVID-19 also, how it was managed globally, we saw how poor leadership can be as deadly or deadlier than the virus itself. So I think we have seen it. I don't have to mention the countries, you know it. So, so it's really important in every angle, particularly during crisis time. So in my own, I come from, as I said, from a village, poor village, with nothing, no electricity, no running water, nothing. But the great equalizer is education. I had access to free education by Ethiopian taxpayers, followed by in graduate school by the American taxpayers. I'm very grateful. But then my destiny was in my hands. So what to do with that education, that opportunity. So I was very grateful. I was happy to be a bench scientist, making discoveries, using the science, the power of science to apply to development challenges. But I think being a CEO of the only organization on the planet that focuses on insects that are important to humanity. It gave me so unlimited authority, first to take care of the staff, close the pay gap, create workplace equity, but also to direct the research also to where it is needed. The technologies, products that are focused on women. If you develop women-friendly technologies and products that are actually a no-go zone also, they become also men-friendly also. So we have made tremendous impact. One of the things I hated when I was a kid was hand weeding. It's really back-breaking exercise. A lot of the back-breaking work on the farm in Africa is really reserved for women. I don't know why. So I hated that thing. But once I have this opportunity, we created technologies, use the power of science to remove that weeding, hand weeding. We developed the technologies that can completely eradicate without chemical weed. And then women were like 65% of the farmers that adopted this technology. We made beekeeping female-friendly by modernizing it and giving it access, and so on. So there is a tremendous satisfaction when you actually use the power of science to make things happen and lift the poor, the unfortunate, and make them smile and change their lives. And I think it should be mandatory for every government to invest heavily in science because our livelihood depends. Without science research, wouldn't be having this face-to-face meeting. If there was no vaccine developed quickly by scientists, we would still have been probably in a lockdown or on mask or something. So I urge everybody to invest in science because our lives literally depend on it. Was it? Thank you.
Well, I would like to thank all of you for a fascinating conversation and for such an important messages resonating from each one of you. And I'd like to invite all of you to the event that will be the BGU Student Kaleidoscope Fair at the Susan Zolotowski Garden, where you will engage with BGU students involved in different exciting initiatives. So thank you very much. And